A very simple question is, what matters to you? It's so basic, but I think that can help a nurse get to, when they're having conversation with a patient, what gives that patient a sense of meaning in their life. And I think one thing that's really important is to know that spirituality and religion are very complex, and there's a lot of diversity within any given group.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS. And today we're talking with Reverend Caroline Peacock, Director of Spiritual Health and Community Care at the Winship Cancer Institute of Emory University in Atlanta, Georgia, about supporting patients' spirituality during cancer care. You can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Caroline.
Thank you so much for having me. It's an honor to be here.
To start today's discussion, can you briefly help us understand what exactly is spirituality and what are all of the pieces and parts that it encompasses?
It's a little bit of a complex answer. The easiest way I would describe it is that which gives meaning in a person's life. And that can be different for different people. For many people, that might take a religious form. And for many people, it does not. It might take some form of, having deep appreciation for connecting with nature or appreciation for connecting with their community or with family and friends. People might have some type of meditation practice that is a part of their spiritual life. So there are many, many different ways that people might connect with their spirituality. It's what gives a person a sense of meaning, a sense of hope, a sense of connection to something greater than themselves.
That's a great holistic definition. And it really brings to attention for me, like the idea that everyone has some spiritual aspect to themselves, even if they don't identify with that term, as you've defined it. There's always something that each person identifies with that is meaningful or brings them joy. And so I think that's an important thing to keep in mind as we as nurses approach patients and try to help support them through their cancer journeys, that there's always something there, whether they define it exactly with that terminology or not. Now, you also hinted at sort of spirituality versus religion. How are those two concepts different?
Well, I think the easiest way to describe that is that, there are some major world religions that we might be aware of. For example, there's Judaism and Hinduism and Christianity and many more. Some people might have a religious identity that is associated with any one of those particular religions. And for some people, they might engage in religious practices that bring them a sense of meaning. For example, they might engage in prayer, or they might engage in some kind of ritual practices. For example, within the Christian tradition, people might appreciate having communion or baptism, things like that. And then for people whose spirituality does not take a religious form, their engagement with their spiritual life might look very different. It might not be organized within any particular group, but it might be more, connected with their individual path within life. And so there are many, many different ways that people connect with these aspects of their life. And when we are approaching patients, my team and I, the spiritual health team, what we want to know is what matters to that particular patient. What gives them a sense of meaning? What gives them a sense of purpose in their life? And we want to approach them without judgment. So if I'm approaching somebody who has a very, very different way of looking at the world than the way I do, I still fundamentally want to approach them with respect and with a sense of curiosity to find out what helps them to cope, what gives them a sense of meaning so that I can be a supportive presence for them while they're on their cancer journey.
I love that. That's just a great, humble way to approach people that are different from us in all different ways, not even just spirituality or religion, just kind of humbly approaching them to say that how you practice or how you go through life is different than me. So I want to understand how it's different and find out the way that I can support you best. So that's just a great way to approach patients in all parts of our care. Now, I think oncology nurses, we're generally very familiar with the idea of distress screening, trying to identify ways that patients are experiencing challenges as they navigate through this journey of their cancer diagnosis and treatment and beyond. But one specific facet of that distress is spiritual distress. Can you help us understand how you see patients in spiritual distress and what is it about a cancer diagnosis that can lead to that spiritual distress?
Receiving a cancer diagnosis can really turn a person's life upside down. It can cause them to face questions of their own mortality. It can cause them to wonder about how they've lived their life to that point. It can cause them to reflect on their relationships with others. And also, living with cancer can be extraordinarily painful and obviously takes a tremendous toll on a person's body, not just the cancer itself, but the treatment regimens that people have to go through. So spiritual distress comes in many forms. It comes in some of those forms of ways of thinking about the world that might be difficult and cause some emotional pain, the way they're relating to the world or the way that they think about their own beliefs. Let's say somebody has a belief that bad things don't happen to good people. Let's just say that. Or let's say somebody has a belief that if they pray enough, they won't get sick. But then all of a sudden they have a cancer diagnosis. That can be very overwhelming and very confusing in relation to their own personal beliefs. And so that would be an example of spiritual distress. Let's say somebody is experiencing a lot of physical pain and they are maybe not able to engage in the same activities that they like to. Let's say that every day they love to take a walk after work with their spouse, but now they're just too tired, too weak to take a walk. Well, that could result in a sense of spiritual distress because they could feel like they're not able to enjoy life the way that they used to. That can bring a lot of sorrow and sadness for a person when they realize their life has changed so much. So when we do distress screening, where I work at Winship Cancer Institute with Emory, for our cancer patients, we ask two specific questions. And these are evidence-based questions. The research on these questions was done by a chaplain clinician out in the Northeast by the name of Stephen King. And the questions are you experiencing spiritual or religious struggle? That's the first question. And the second question is, are you experiencing a lack of joy or meaning in your life? So we ask all of those two questions to all of our patients at their second visit with us at Winship. And then they receive those same questions every 3 months during their first year of treatment with us so that we can be tracking their spiritual distress, among other items relating to distress.
I think that's a really succinct way to ask those questions and get the information that you and your team needs to kind of intervene when those responses indicate that that patient really is struggling. And I know, speaking from the clinician's point of view, those are parts of the patient's experience that I think, especially in a fast-paced clinic environment, seeing patients trying to move them through their treatment, that even if we feel compelled to want to ask those questions, as challenging as they are, we also feel limited in our ability really to spend that time to help work through them. And so members of spiritual health team, such as yourself, are so crucial to helping us address those issues and not just merely measure them with screening tools. So along those same lines, how do you see spirituality and maybe spiritual health care? What is that role within sort of the clinical context of testing and treatments and all of that? How do you see spirituality being addressed?
I'll start by speaking about the outpatient context. We interface with patients in a variety of ways within the outpatient context. So the first thing we do is when patients are having their cycle 1, day 1 of their very first chemotherapy regimen, for example, or if they're having a change in their medication and they've got a new cycle starting, we visit with those patients in the infusion center. And the infusion center is a really great place to interface with patients. And that's because they're often sitting there for several hours and they often have to wait for their medications to be mixed. And there's a lot of waiting. So we interface with them during that time and we can kind of check in with them how they're doing on their very first day. The other thing we do is we call patients during the week when they're having their simulation appointment within radiation oncology, just as a touch point, because we know that can be really stressful starting radiation treatment. We also follow up on any referrals that we receive from nurses or providers for a patient who might be just generally experiencing distress and they want somebody to come in and see them. For example, let's say somebody's just gotten a new diagnosis, or let's say they're really overwhelmed in their clinic visit, they might call us in to spend some time with that patient. And then in the inpatient context, we certainly have a lot of interface with patients. We try to see all newly admitted patients across Emory Healthcare, including our oncology patients. In those oncology settings where people are spending lengthy times, for example, in the bone marrow transplant unit, we certainly try to interface more regularly, and we often receive a lot of referrals from incredible nurses who are really working so hard, but may be limited in their capacity to tend to the spiritual and emotional aspects of the patients that they're caring for. So that's when they call us in, and we try to help patients in those instances.
As you've talked through it, I've been thinking about how this is sometimes a difficult conversation, I think, for patients to initiate on their own when they're having these feelings. And so I think the screening certainly is a nice sort of introduction to having them maybe really finally kind of admit or put down to paper that, yes, I'm struggling with this or I'm having difficulties. But even if they're not, I love how you provided those examples of patients in our care a lot, especially in outpatient. We see them frequently, or at least regularly. And so sometimes it's just a matter of being introduced to your team, to those people that are there to help address or support any spiritual needs whenever they happen. And maybe when they first meet you or your team, they're not struggling or they're feeling okay. But even just being able to put a name and a face to those resources that are available, I think is a great example, especially calling patients at home just for a check-in, not as a reaction, but as a proactive step to say, we're here. We know that you're going through things. We want to be available. So I think that's a great model for other sites to consider of how can we plant that seed of, you may not need us now, but we want you to know we're here. And I think that's so important, especially when we're talking about the spiritual distress that we're discussing today.
I'll just say that sometimes I refer to that with my team as buying insurance with the patient, that when we meet them, that very first time, they might not really feel the need to talk to us, but it's almost like an insurance plan. They've met us, they know we're there, so that when they need us down the road, we've already got that touch point with them. They remember who we are and we're able to follow up with them. And so when they're in distress, they can say, oh, I remember there was somebody who actually tends to these issues. And so I can speak to them. And I just wanted to respond to one other thing that you said. One of the things I often say to nurses and providers is, if you have a patient who's experiencing distress, I often recommend that you don't say, would you like to see the chaplain or would you like to see spiritual health? I often recommend that you just make the referral and that we will just come in and we know how to interface with the patient. And the reason I recommend that is because a lot of times there's a stigma associated with receiving help when someone's in distress. And so often if you ask that question, if you put that burden on the patient to say that they need the help, they will say no. Whereas if you just make the referral, we know how to come in and come alongside the patient and provide the necessary support in a way that doesn't make the patient feel embarrassed or like they're being needy to be asking for that kind of help.
Oh, I think that's so important. Thank you for bringing that up. It really goes to the heart of why we call it distress and not stress or emotional concerns or, psychological problems. I mean, all of those are very loaded terms, very loaded words. And so in the same way that we try to just under an umbrella of distress, make it a little bit more approachable and less stigmatizing to say, yes, I'm struggling, because you're absolutely right. Whether it's with spiritual health or any of the other various things that patients can struggle with, it's very hard sometimes for people to ask for help or admit that they need help. And I think especially when we're talking about spiritual health, which I'm sure we'll talk about more here shortly, but we as clinicians, most of us, I would say I'm sure there are some, but we're not trained to talk about spiritual issues. That's not our specialty. And so sometimes, though we're trying to help, we can fumble a little bit and maybe ruin what is a good opportunity to try to make that connection. So like you've said, sometimes just make that referral, and then you and your team and those wonderful people who are trained specifically on how to approach patients and the words to use and the way to invite that conversation gently will take over and do what you guys are best at.
Yes, absolutely.
So we've talked a little bit about this already, but aside from actual physical locations that you and your team can interface with patients, what are the specific touch points along that cancer journey that you think it's important for the clinical team to sort of interface with the spiritual health team to make sure that patients are supported at certain kind of milestones of their care?
I don't think that there's a clear sort of science behind this. I think it's really dependent on the particular patient. Obviously, when a person has a new diagnosis, that can be so overwhelming. Often, once they have a plan in place with their provider, their distress goes way down. So I do think that after that first diagnosis, that's often a point when we might want to interface. And then, when there are changes in goals of care, for example, somebody is getting ready to consider transitioning to comfort care, for example, or palliative measures, that is a very important time. And that's often when we're called in. But then, there's also things like around the holidays, like where we are right now. People might have a lot of distress leading into the holidays, a lot of sadness. And then one thing I often say is that people who have cancer are people before they have cancer. So they have complicated lives already. And then on top of their complicated lives, they also happen to have cancer. And so whatever complications a person is having in their life that are outside any particular points on their cancer treatment journey, those aspects of their life might need tending to. So for example, let's say somebody's having marital distress, or somebody's experiencing problems parenting their teenager, or somebody has an elderly parent who has just died. People's lives are already complicated. And so a lot of times we're responding to issues around those matters for patients as well. It can be at all different points where we might be attending to the patient and to their loved one. That's the other thing. Is one thing that's unique about spiritual health is that the family, the loved ones, are just as much of our care seeker as the patient is. So we may sometimes be primarily responding to the family member based on whatever the need is for that particular patient and their loved ones.
I think the points you've brought up just about how people's lives are already complex and sometimes difficult or complicated, and that's their starting block for when they get their cancer diagnosis. And so to me, it just emphasizes the importance, especially for nurses, because I feel like this is our realm. This is sort of our wheelhouse to be in, is understanding the holistic picture of that patient, what they're coming to their diagnosis and treatment with, especially, for clinical details, transportation, practical matters of can they get to treatment? Can they afford their medications? Can they pick things up? All of that. So all of that's important. And if you don't get a good baseline understanding of what that patient is dealing with, inclusive of spirituality, how can we expect to create a treatment plan that factors in all of those various things? So you're absolutely right. We have to meet our patients where they are and understand where they are before that we can try to intervene in ways that are meaningful and helpful. So I really appreciate you bringing up that point. So what are some, we've all probably, as nurses, we've all heard patients say things or maybe experienced something. For what are some of the more common spiritual health, spiritual distress issues that you frequently will discuss with patients or their families?
In my experience, the thing that causes people the most distress is matters relating to people's families. Let's say somebody has a terminal diagnosis. They're concerned about how their family is going to be after they die. That's a very common thing that we are talking to people about. Or maybe feeling guilt that they're not able to interface with their family the way they used to. That's very common. And then people do have a lot of distress around the issue of death, around what it will feel like, fears around death. That's something that we commonly are talking to patients about. And then people have spiritual or religious wonderings as well. For example, if they have a particular belief, like let's say somebody is Christian, for example, and they have a particular way of experiencing their Christianity where they think if they're sick, that must mean they're receiving some kind of punishment. That is something that they might want to explore with somebody from our team. And something that's interesting that I've experienced over the years is that people often have religious leaders in their lives that they may be connecting with as well. But something that's unique about the role of the spiritual health clinician is that we are sort of neutral when it comes to what their particular belief is. So let's say somebody is experiencing some kind of conflict in their belief. It might be hard for them to bring that to their religious community because they might feel a little bit worried about how they might be perceived. They can bring that up with us and we won't have any judgment around that because we are approaching them with a certain amount of neutrality. So those are some of the kinds of religious issues that people might come to us with. And then we also want to instill hope when people are wanting to seek hope. And so let's say somebody values prayer and they ask us to pray with them. We will always love to pray with patients and support them in their religious beliefs however we can, if that's something that's important to them.
Those are some really great examples. I know I can recall a handful of times in my own clinical practice where those types of concerns have been brought up or hinted at maybe by patients or their families. And I think just emphasizes the importance of knowing who within your clinical site, your institution, if you have those resources. And unfortunately, I think the reality is that not all places do have spiritual health clinicians on their staff or, accessible anytime, any day. And so I think the challenge many nurses are facing is hearing these concerns and this distress from patients and maybe either not having great resources to refer them to or convenient or accessible resources or having them immediately available. And so it's great to hear those examples. And so nurses can now be a little bit more mindful of hearing some of those concerns and thinking already kind of planning ahead. Okay, what will I do? And how can I help this patient if for some reason they don't have someone they can call to come down relatively quickly to talk with patients? So those examples are very important to have. You've already kind of explained how spirituality connects to a patient's sort of meaning in life, and essentially it impacts their quality of life. So can you describe how that spirituality or maybe the distress they're having in their spirituality really influences their quality of life throughout their cancer treatment?
I think just like people who are not living with cancer, when we are able to connect with the things that give us meaning in our life, it just makes us stronger. It makes us happier. It makes our life more fulfilled. I think of it almost like an immunization. Let's say I wake up in the morning and I do things that are good for me. Maybe I engage in some spiritual practice that I know is important to me. Let's say I eat a healthy breakfast and that sustains me through my day. I'm doing things that are sort of like setting me up to succeed in my life. Well, the same thing goes for people who are living with cancer. If they're able to connect with things, with practices that give them a sense of strength, that give them a sense of meaning, maybe that's listening to gospel music in the morning, or maybe that's saying a prayer when they wake up or lighting a candle. If they're able to do those sorts of things, if they're able to connect with the things that give them a sense of meaning, that strengthens them through their day. And so I think, just being able to support people in making those choices in their lives, that can help them to lead better lives while they're living with cancer. So spiritual health clinicians just lift up those aspects of ways that a person's life can be improved. They have so much on their mind while they're living with cancer that they might not even be realizing that they could do a few things that could just benefit them emotionally and spiritually in this way.
It seems like we save that question, and I'm making some generalizations, of course, but it seems like we save that what's meaningful to you, what's really important for you. We save that question until end of life. Like we save that until we know that we're at the end of the road, maybe for treatments. But how much more helpful would it be if we made that the first question we asked, not only so that they prioritize those things, but as you just said, if they can early on identify like what's meaningful for me, what do I love, what do I enjoy, incorporating those things, they can be small, simple actions, as you mentioned, just making sure you're doing a healthy breakfast, making your bed every morning so you feel like you've gotten something done, just helping them to identify those small, but, important things that give them that sense of maybe accomplishment or just taking care of themselves. Incorporating those things throughout the entire trajectory of their care could be so beneficial, and not just waiting until we're having that sort of goals of care, end of life discussion. It just strikes me personally, I'm like, we should be changing the order of that conversation and that question, move it to the beginning. Ask it again later, of course, but we should ask it first.
That's why we call our discipline spiritual health, because we think that this is about the health of the person throughout their journey. It's not about just calling in the chaplain at the last minute. It's about
waiting till they're in crisis, waiting until they're in crisis, like incorporating it routinely.
Exactly. Supporting their health.
I love that. We have talked about a few obvious examples of patients declaring concerns or questions or distress that they're experiencing, but are there any other more subtle indications or signs that nurses should be aware of, just to be mindful if a patient might benefit from talking to somebody on the spiritual health team?
There's a lot of different circumstances when a nurse might want to call in spiritual health. Like if a patient is feeling really angry, for example, that's a time they can call spiritual health. Or let's say they're having conflict with their family, they can call in spiritual health to help support them in conversations that they might be having with their family. Let's say they're having some cultural dilemmas relating to their care. Like an example that might come up is a Jehovah's Witness patient who is not wanting to receive blood products. Sometimes that's a very clear line, and sometimes it's a little bit more nuanced. And so the patient might want to speak with spiritual health about those dimensions. We are also involved in a lot of ethics consults. So sometimes we serve on ethics consultations teams, and we're brought into those conversations. I think if a patient obviously is crying, is overwhelmed, is sad, that's a time that a nurse can call in spiritual health. And let's say a patient is just talking your ear off. You're the nurse at the bedside and the patient is just talking your ear off, and the nurse just doesn't have the time or capacity to tend to the patient. It might be helpful to call in spiritual health to provide a little bit of companionship for that patient. And that can actually help the nurse to be more effective in their work so that they're able to tend to the medical needs that they're needing to get to, while we can absorb some of that spiritual and emotional content that the patient might be carrying.
I think that's so important. And it just directly addresses that this is a team. This is a team effort to care for our patients holistically, that no single member of the team can or should be expected to address a patient's every single need. And that's what care is. Everyone's individual parts are amplified when we work together so that we can each do what we're specialized and best trained and adequately prepared to perform for that patient. So that's a great way to describe how sometimes nurses will say, oh, this patient's really chatty, but that's important because sometimes it's just a way for them to sort of let off that steam or that emotional buildup. Hearing you describe it, that companionship, sometimes all they need is just someone to be there with them, or even if they don't want to talk, sometimes just being with them.
Exactly. We spend a lot of time in silence with patients, just sitting by them. If they want to hold a hand, if they reach out their hand, we can hold their hand. That's certainly a part of the work that we do as well.
So I know I speak again for myself, as I always try to do, but it has always, I think, been challenging for me to tend to my patients' spirituality To start, before we get to actually trying to address difficulties that patients are having, what are some actions that nurses can take just to better understand maybe a patient's spirituality, their religious affiliation, or just kind of what's important to them? What are some techniques that nurses can use to better understand?
A very simple question is, what matters to you? It's so basic, but I think that can help a nurse get to, when they're having conversation with a patient, what gives that patient a sense of meaning in their life? Very simple question, but it can get to a lot. And then the other thing is, all human beings, we're sort of drawn to have assumptions about people that we're engaging with. And I think one thing that's really important is to know that spirituality and religion are very complex, and there's a lot of diversity within any given group. It's important for nurses to know that when they're interfacing with a patient of a particular religious background, not to assume that they maybe have all the same beliefs as other people within that particular religious group. There's a great deal of diversity, and spiritual health clinicians or chaplains are really trained to understand the complexity of these different groups. I would encourage nurses to just not make assumptions about what a patient wants or values before allowing the patient to articulate that for themselves.
And as nurses try to address spirituality, and if it's challenging for nurses, sometimes they are uncomfortable with their own spirituality or religious affiliation, or if where they kind of land on that spectrum, maybe they're still kind of figuring it out themselves. And so are there any introductory questions, ways that they can start those conversations with patients to really help move that conversation in a way that's comfortable for both the nurse and the patient?
Well, I think they can just simply say, tell me about yourself. What matters to you? How do you like to spend your time? What gives you meaning? A general question could be, are you a part of any religious or spiritual group or community groups? That's a way that they could kind of gather a little bit of information. But I think the best thing to do is just to pay attention to what the patient is talking about. And they will tell you what matters to them. So I think more than anything, creating an open and allowing environment so that the patient can share what matters to them, that's a way to get to those aspects of their spiritual life.
I think you've perfectly explained really the notion of implicit bias, that we all come to approach our patients and the care we provide with those implicit biases that are inherent in everyone. And so the work is to look inward, identify kind of what are your preconceived notions or biases that you hold, and then finding ways to set those aside when you're caring for patients that might fall into some of those biases that you hold. And it's not a judgmental thing. It's really just identifying that we all have them, but the work is to identify them and find ways to ensure that they don't negatively impact the care that we provide. And I think that certainly is in the cultural realm, which spirituality is part of a person's cultural identity. So I think all of those things really just, as you've already said, asking questions, being humble and asking questions and admitting you don't know and you want to learn more, I think is really a simple way to approach when you really aren't sure of what a patient, whether it's a spiritual or religion question or just what's important to them, asking those questions and being okay with saying, help me understand, because I don't want to make those assumptions. I think that's okay to be vulnerable enough to say that, I don't know, but I want to learn. So help me understand.
I remember a few years back, I was at the deathbed of a patient, and this particular patient and their family, they were Jewish. The nurse was a very loving nurse, a very competent and kind nurse. But I remember that in the language that this nurse was using with the family, she said something like, I know you're going to see your loved one again in heaven. And that was not a religious concept that this particular family embraced, this concept of heaven in the way that the nurse thought of it. And so this nurse was really, really well-meaning, very well-meaning. But I remember the face on the family member when she said that, and I could just tell it was a miss. And that was unfortunate because it was an example of that kind of bias that you're talking about. Like, she was really meaning to do the right thing, but she just didn't realize that the language she was using was not a cultural fit for this particular family. So I think just as people are going into these kind of high stake situations, particularly around death, particularly around living with cancer, for all folks to be able to examine what their assumptions might be can be really helpful to creating an inclusive and supportive environment for our patients.
I think we need to call out the reality that these are really hard conversations to have. These are challenging things to talk about, even if we're just talking about them with our own personal family, about ourselves, sitting down with maybe our aging parents and asking what are their goals? What are their wishes? Like, that's hard. So imagine having that conversation with someone who's essentially a stranger. So I think it's easy for as you said, well-meaning, best intentions, but sticking our foot in our mouth or, just blurting out things that we hope that's helpful. We're trying to help, but sometimes it's just, we haven't developed the skill of what to say, how to say it, when to say it. All of that is part of training that as nurses, we don't routinely receive. And so again, just really highlights the importance of having collaboration with the spiritual health team so that we can provide that care in the best way to meet the patient's needs. Especially the past 2 years and some of the turmoil that nurses have been through. How do you interface with nurses who are experiencing spiritual distress? Do you talk with nurses? Do you have advice on nurses who are struggling with their own spiritual health?
At Winship and at Emory, 50% of the work that we do is staff support. We consider our healthcare staff, and particularly our nurses, who are a huge bulk of the makeup of our staff, we consider them to be part of our groups of humans, of people that we're responding to. And my team and I care deeply for the nurses that work within our healthcare settings. Just like I said before about how patients have complex lives, nurses have complex lives. And they're dealing with all kinds of things within their own lives, challenges with family, employment, stressors, really working very hard hours, having really hard patients, having heavy caseloads. All those things can be extraordinarily overwhelming for healthcare staff and for nurses in particular. And so the way we respond to nurses is we provide support all the time. And often this is just happening at the nurses station, in infusion, or on a clinical unit. When we're in the room with a patient and we notice the patient is rude to a nurse, or we notice that the nurse may feel stressed and overwhelmed, when they step out of the room, we might then go and check in with that nurse. Sometimes I refer to caring for staff as the water between the rocks of what we're doing. It's kind of everywhere. It's ubiquitous. Staff support is a huge part of our mission. We just want to support our nurses as much as we can within our healthcare context.
Well, that sounds wonderful. And thank you for spending that time to care for those nurses and to be attentive to needs that they might have. I'm sure it's greatly appreciated by the entire nursing team there at Emory.
One thing I always do, if a patient asks for a prayer, when I'm praying for the patient, I always mention the nurse in the prayer. And that is so that the nurse can hear that they're appreciated. It's an appreciation coming from me, but it's also a cue to the patient to remember that this is a valuable person who's caring for them. I just really want to honor the work that the nurses are doing. And so I always include nurses in my prayers when I'm praying with patients.
Oh, I love that. Thank you. Oh, that's beautiful. Well, Caroline, thank you so much. Such a great conversation today. A really important and a tough topic, but one that I know nurses, we want to know more about, and we want to be better at addressing the spiritual needs of our patients. So thank you for sharing all of your great information and tips that we can incorporate into our own practice. As we wrap up today's episode, I do like to ask a few just kind of quick questions to summarize some of the things we've talked about. So to start off, what are some common misconceptions about spirituality and cancer care?
I think the biggest misconception is that people only need to attend to spiritual issues at the end of life, whereas it's actually something that's important throughout life. Another misconception is that spiritual health clinicians are only responding to religious needs, and actually our care is much more expansive, attending to all kinds of issues that a patient might be experiencing.
What is something about this topic that's not often discussed, but you wish people knew more about?
I wish people knew more that we are there to support staff, that's 50% of the work that we do.
What additional training or resources do oncology nurses need to understand spirituality and how it impacts cancer care?
I think there's some really great palliative care training out there. I think it's called the CAPT training. That's a very comprehensive palliative care training. And palliative care encompasses spiritual care, and nurses can go through that training. And I think that's a very helpful resource.
And what are some additional resources for patients or providers who want to learn more?
Well, they can certainly go to our website, the Winship Cancer Institute website, and they can go to the spiritual health section of that website. And then also our general spiritual health Emory website has a lot of information about spiritual health. We have a whole bunch of videos, both for patients and staff, that are wellness related in terms of offering meditations and how to deal with stress, that kind of thing. And those are some helpful resources that nurses who are listening might like to take advantage of.
Wonderful. Do you have any final comments to share with our listeners today?
Just my deep, deep appreciation for the work that you do. I have a great appreciation for oncology nursing. And I really thank you, Jaime, for asking me to come and speak to your listeners today. Thank you so much.
Thank you. Again, thank you for sharing your wisdom and your wealth of knowledge with our listeners. It's been a wonderful conversation.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.